Hello everyone, welcome to today's recall session. Good evening to all of you. So I hope the subject pediatrics has been interesting to learn in the first go. It is totally based on the concepts and we are going to revise some of the important concepts and some of the important topics that we have already done before in the lectures. So I would like to request all of you to start the session with full confidence that yes, you know the subject very well. And the questions which are going to be asked is just a recall session to help us remember whatever we have already studied. So first, we are going to discuss some of the important topics. And also I would expect the students to be very interactive in the session. So whatever questions are being asked, I expect you first to prompt the answers in the chat box. And also for those who are not able to answer in the first go, all of you must try to understand that why it is the answer and how we can exclude out the wrong answer in the question. MCQs are always based on concept, and the best part is that the answer is right there in front of you. So you don't need to mug up and remember each and everything. If you know the topic, if you know the concept, if you read the question patiently, you'll be able to understand everything. So I hope many of you have already joined the session. So can we begin? Please put in the chat box. Please type in your responses. Are we ready to start the session? All right. So all right. So we have many students who are ready. Preeti, Shankar, Nitya, Aditi. Welcome to all of you. So whenever you put in the responses, I would also mention the name of certain students. So one by one, all of you can interact and start with the answers. Okay. So let us start to discuss the important things first. Okay. So the first topic that we're going to discuss today is very interesting. That is autism. To be really shocked because it is some of the topics which are generally not asked in the exam very often, but it is one topic which is very scoring because it is based on simple concepts which basically we see in our daily lives also. So autistic children are very commonly seen and we miss the diagnosis easily. Why? Because it is difficult to diagnose in the first go. There are certain criteria that help us to diagnose this particular clinical condition. So how many of you have watched the movie My Name is Khan? Have you guys watched the movie My Name is Khan? Please type in your responses. See, the class has to be interactive and we expect everybody to, start to speak up and put in your responses in the chat box. Okay, no. So that is fine. Now, My Name is Khan is one of the common movies that I think most of you must have watched. It is basically based on the autism and it is based on the autistic behavior. So you must have come across certain children who don't like to interact too much, who don't like to, speak socially, who don't want to have a lot of friends in the society. They're usually sitting in a nutshell. They like to do certain activities and they are very restricted to their own lifestyle. So this is basically a behavioral disorder which develops very early in the age. So we have discussed this chapter on autism in the video classes earlier. So let us see the questions which can be asked from this topic. Okay, so the first question is, autism spectrum disorder is a triad of qualitative impairment of which of the following? So simple question which says, what is the classical triad of autism? So very simple question. Who would like to answer? First option says whether it is a triad of social behavior, communication skill, and stereotypic and restrictive behavioral pattern. The second option mentions whether it is learning abilities, social behavior, and communication skill. The third option mentions gross motor development, speech, and learning abilities. And the fourth option is memory, stereotypic, and restrictive behavioral pattern, and also related to social behavior. Okay, so Darshini has answered option A, Shankar has answered option A, Preeti option A. Okay, so that is very nice. So it is a very simple question and yes, the correct answer over here is option number A. So autism basically is a very simple triad. You can remember by the mnemonic SSC because autism has this letter S, which is a very normal word association that you can make. So first S is basically for social behavior problems. So social behavior means they're always very restricted. They will not interact too much. They will not show their response in the society. Like even if you crack a joke in front of them, maybe they will not laugh. They will have a very monotonous look on their face. Or maybe an older child who goes to a place where somebody has died and everybody is grieving and mourning, maybe they'll not respond in that particular way. So that social interaction is very much restricted. The second S is for stereotype. So stereotype basically means somebody who wants to do a particular thing again and again. They don't like any change in their timing and schedule. So they might like love to sit in a closed room and play with their own toys, maybe simple one or two toys. They don't like to go out and make friends. They don't like to go out and do a group play. So stereotypic behavior is to do a repetitive thing again and again. They might just, keep on tearing a pieces of paper and be happy in that particular thing. So that is a stereotype kind of behavior. And C stands for communication problem. So communication basically is they don't like to communicate. If you will sit and like to talk with an autistic child, they will not respond usually. So that is all about the classical definition of autism. So very good. All of you have given the right answers. So let's move on to next question. Now, what are the common causes of autism? What are the common causes of autism? So anybody who would like to answer this? Please put down your answer in the chat box. Now, there could be multiple answers also in the MCQ. Don't just go by that, yes, only one answer is right. There can be multiple options. So please try to jot down all the important causes of autism. Okay, Shankar has answered E and A. Preeti has said A, D, and E. So A has already come up, D has come up, E has come up as an answer. Any more responses? C has also come up. Any more responses? Nitya has mentioned A, D, E along with C option. Anybody thinks Down syndrome can result into autism? Yes, very good. Yes, so Down syndrome can also result into autism. Okay. And what about maternal TPO antibodies? What is TPO antibodies? It is going to affect the thyroid function. So all of you know that thyroid is very, very important for the development of brain of the baby. Thyroxine hormone and the thyroid functions. If they are not, if the thyroid hormone is not working properly, if there is decrease in the thyroid functioning in the early stages of life, it can result into mental retardation. So yes, maternal TPO antibodies can also result into problems of autism. So simple trick to remember, you don't have to mug up the entire list basically. It's simple thing. All those disorders which can result into developmental delay or all those problems that causes mental retardation. All of these can result into autism. So basically, it's going to decrease the developmental output of the child, the way the child is going to grow socially, the way the child is going to interact with the society, have communication skills. So all of these are going to be diminished in those children who have any kind of genetic predisposition, associated Down syndrome, Fragile X syndrome, tuberous sclerosis, increased age of the mother and father, or any thyroid-related problems. Neurofibromatosis is not to do with any kind of autistic behavior in the child. Is that clear? Any doubts anybody has, you can definitely come up with your doubts also, or we can move on to the next MCQ. All right. So third question is deficit in social communication and social interaction in the autistic child includes. Now, this is a very tricky question. Please take your time to read the question and answer very, very carefully. Deficits in social communication and social interaction. That is one of the classical criteria which is present in DSM-5. So that is one hint I'm giving you. As per the DSM-5 criteria, this is one bunch of disorders or behavioral patterns seen in autism. So don't mix up the options. All four are right, but the question demands deficit in social communication and social interaction. So which option is correct and which is not correct? Again, it will have multiple options. Second clue I've already given. Please try to answer. Anybody who would like to answer this? Okay, Nitya has answered option B. That is one part of the answer. Apart from that, what other options could be correct? What do you mean by decreased social communication and social interaction? That is one broad category of DSM-5, but it has got certain subcategories also. Option number D. Okay, that is the trick over here. Option number D is not a part of this DSM-5 criteria. Okay, so for diagnosing autism, we always follow DSM-5 criteria. Now, DSM-5 criteria has got two important broad categories. The first broad category is what the question mentions, that is social communication problems and social interaction problems. And the second broad category mentions the problem with behavior repetitive behavior or movements, that is motor problems, or any kind of behavioral problems, but which is related to their repetitive behavior. So in social communication, we have three important subparts of it. So these important three subparts are exactly those which are mentioned as options A, B, and C. So the right answer is option A, option B, and option C. So social communication and social interaction deficit basically means the child will not have a social emotional reciprocity. As I mentioned earlier, if you're going to crack a joke in front of autistic child and you expect the child to laugh out, maybe the child will have a moon-like face. He will not at all laugh at your joke. So that is basically the emotional reciprocity is not there. Deficit in non-verbal communication used for social interaction. Like whenever we meet somebody, we generally pass out a smile. So if you smile at an autistic child, maybe he will not smile back at you. So these are non-verbal gestures which a normal human being has. If you wave bye-bye at an autistic child, maybe he will not wave you bye-bye back. So that kind of non-verbal communication is also affected. Third important subpart over here is deficit in developing, maintaining, and understanding relationships. So relationship in childhood is not the relationship that we are thinking about. It is basically the relationship with their parents, with their peers, and with their friends. So they will not have a very friendly relationship. Like if you try to be a good friend or a best friend of an autistic child, he might not be able to maintain that depth of the relationship in terms of friendship. Okay. So deficit in developing and maintaining relationship is all based on emotion. So they will not have very good interaction with their parents. They might not be very interactive towards their grandparents or friends or school. Any kind of place, they will not be able to interact too much. So these three are the subparts of the first category. Sorry, that is social and emotional. And the second important part is the problems of repetitive behavior, right? So repetitive behavior means basically the child is always trying to have certain type of repetition of their activities. So they might be always indulging into kind of repetition of activities. That is one part. Second part of this important criteria is that they always insist on the sameness of behavior. That means they will not be very much comfortable in changing their routine and in changing of their environment. So they will always want the same routine and the same kind of things to happen around them. They will always have decreased flexibility. They will not be very much open towards changes in their environment. And the fourth important subcategory in this is hyper or hyporeactivity to sensory input or unusual interests. So these are the important subparts of the second DSM-5 broad category of repetitive behavior and problems in the movement. So it's very important to know that whether the DSM-5 criteria is fitting in our diagnosis or not. So that is how we always do a diagnosis of autism. Okay, mothers should understand. Motherhood, they understand. I mean, are they able to interact with mothers? See, an autistic child is always able to interact, but the level of interaction we expect from a normal child, that will not be present in autism. If you ask a child 50 times about whether you want to have food, maybe he will not reply 45 times. Maybe he would reply one time, or maybe he can only give a sign that yes, he's hungry. So normal interaction, talkativeness, and normal kind of playful behavior that we expect from children, that is going to be absent in autism. Okay. Okay, next question, question number 4. Restrictive, repetitive pattern of behavior, interest, or activity is seen in autistic child include all of the following except. I just mentioned the important parts of this DSM-5 broad category. So if all those who have listened carefully to what I said will be able to answer this question very easily. So there are important 4 subparts of this broad category. So what is not present in the second DSM-5 broad category. So what is the answer over here? Please put down your answer in the chat box. Yes, Preeti, that is absolutely right. Deficit in social emotional reciprocity. Now, social and emotional reciprocity falls under the first broad category, that is social and communication skills. The second broad category, that is basically restrictive and repetitive pattern of behavior, includes these four important points. They always want repetitive motor movements. That means they will always keep doing a particular activity again and again. They'll always insist on sameness of behavior and routine. They don't want any change in the schedule or routine. They always want the same things to happen. They are not comfortable to changes in the atmosphere. Highly restricted, fixated interest. Again, they're not flexible. If you want them to go out and play in the playground, they will not go. They would love to sit back in their room and do any kind of activity, or maybe just, fidgeting around with papers or any kind of thing that they want to do. So they're not flexible. Hyper and hyporeactivity to sensory input or unusual interest. So they might suddenly have a burst of laughter out of no reason. Like normal people might not laugh so loudly at that particular thing, when an autistic child can show a hyper-stimulated response. Similarly, hyporeactivity. Maybe you have cracked a very nice joke and everybody is laughing at it, but that particular autistic child might not respond to that level of activity, that level of joke. So basically, hyper and hyper-responsiveness to kind of sensory input. So these are the four important subparts in the second broad category of DSM-5. Now, this is very important to be memorized, because in exams and in MCQs, the examiner would always try to mix match and make you confused. So please remember the important broad categories and the subcategories, okay? All right, so next question on autism. So what is the treatment of autism? Very simple. If you have understood what is this disease of autism, what are the clinical presentations, it's very simple to answer. The treatment of autism. So please put down your answer. Again, multiple answers are over here. Okay, so Nitya mentions A, Preeti mentioned A, Shankar mentioned A, B, and C. All these are right. Any more responses? Darshini mentioned A and C. Anybody who can mention all the answers in one go? What are all the important treatment protocols for autism? Okay, so A, B, C, any other response for this? So these are definitely correct. Behavior therapy is one of the most common treatment that is given for autism. Educational therapy is very, very important, because their way of educating is also different. Communication interventions is very important. We need to teach them communication skill. But apart from that, another important category of treatment, apart from behavioral skill, is the medication part also. So please remember, medication is also important in autism, and we do give antipsychotics, mood stabilizers, and melatonin therapy to regularize their sleep pattern. Okay. So all of these are parts of their treatment. Muscle relaxant has got no role in treating autism, because they don't have any motor defect in their body. It is a behavioral problem. So very easy to guess, muscle relaxants will not have any role in autism. So are we all clear about autism? Please give a thumbs up, those who have understood the topic and were able to understand the MCQs and arrive at the right answers. All right. Anybody who has any doubt, please keep posting. Okay, thank you all of you for the response. So can we move ahead to the next topic? Any doubts, anybody? Melatonin is given to regularize their sleep pattern, so that they can sleep at a particular time and have a normal behavior. So that is why melatonin is given for sleep therapy. Okay. All right, so let us move on to next important topic. Very easy topic, hypocalcemia. So what do we do in hypocalcemia? What are the clinical presentations? What is the treatment? What are the causes? Okay, first important question. Common clinical features of hypocalcemia include, so if a child has got hypocalcemia, even a newborn has got hypocalcemia, what could be the clinical presentations? Again, multiple answers are here, so please take a moment to understand the question and type in your responses. A and G have come up. Okay, that is right. B, E, and G, that is also right. Any more responses? What about pain abdomen, exaggerated startle response, cyanosis, tachypnea? Can these be features of hypocalcemia? Yes, all of them can be features of hypocalcemia except pain abdomen. Have you ever seen a patient who has hypocalcemia presents with pain abdomen? Okay, so Preeti has answered absolutely right, except C. All other options are right. Very good, Preeti. So pain abdomen is a classical presentation in hypokalemia, not in hypocalcemia. Please remember that all the abdominal discomfort and all the abdominal pain features come in hypokalemia because potassium is very important for muscular functions. And if there is hypokalemia, it can result into decreased motility. It can cause pain abdomen as well. Okay? So in calcium, what is basically very, very important? Now, calcium has a lot of roles in the body. It is not only the bone strength that is important, it is also the muscle strength that it's going to give, and also it has got neurological importance in the body. Okay, so whenever a baby or a patient has got hypocalcemia, what will happen? There can be myoclonic jerks. So myoclonic jerks is again to do with the muscular component. So these jerks basically happen because of decreased calcium level, and the DTR or the deep tendon reflexes become a little exaggerated. Apnea, laryngospasm, again very important. There will be problems in the respiratory system. Laryngospasm is again going to happen because of hypocalcemia. So the vocal cords that we have, they can go into a spasm. So if the vocal cords go into spasm, what will happen? The air entry will be decreased. Because of this, the patient can go into episodes of apnea, which is more common in a newborn baby. Exaggerated startle response, again a classical feature in a newborn in case of hypocalcemia. Cyanosis, why will cyanosis happen? So as mentioned, laryngospasm can decrease the air entry. So once the oxygen level is going to fall, the baby can turn blue because of hypoxia. So cyanosis can also happen. Tachypnea again is very important. So tachypnea is the initial response that baby is going to try to increase the oxygen level by having a raised respiratory rate. So increase in the RR is the initial response. So tachypnea can also happen. And seizure is very, very common. So decreased calcium and decreased vitamin D level. Two very, very important and very common causes of having seizures in smaller kids. So seizure is a very common presentation of hypocalcemia. DTS initially will be brisk and gradually it will be reduced. So both responses can be seen in the initial stages of hypocalcemia. There can be a brisk response also. Is it clear to all of you? Any doubts about this question? So there can be other clinical features also, but please be clear that pain abdomen is classically seen in hypokalemia, not in hypocalcemia. All right, can we move to the next question? Any doubts anybody has? Okay. All right, next question. Treatment of hypocalcemia includes all except. Always be very patient to read the MCQ. Don't be ever in a hurry in the exam also. Many of us tend to miss these important terms, all except. All of the following are true except, which is the false statement. So first understand the meaning of the question. So what is the treatment protocol and what is not required in a case of hypocalcemia? Please read the question carefully again. Preeti, you have been answering right answers. Please read the question carefully. It is asking all except, which does not have any role in treatment of hypocalcemia. It's very simple. There's decreased calcium level. What is not needed in the body? Shankar, calcium supplementation is the most important thing. If something is decreased in the body, you will give that thing from outside source, right? Yes, very common thing to understand. Phosphate supplementation. Why do you need to give phosphate? We don't know the cause of hypocalcemia. The question is simply telling you hypocalcemia is there. What can you do? If nobody has even read hypocalcemia, then also you can use your common sense. So don't be very afraid of answering MCQs. The best thing is the answer is there right in front of your screen. You just have to maintain your calm, be confident, use your common sense, and then answer. Maybe you have not read hypocalcemia in your entire textbook. You have not listened to any lecture. So if somebody asks you in the body sodium is less, what will you do? Obviously, you will give salt to the baby. Maybe you will infuse normal saline. So anything that is less in the body, you'll give from outside source. So first option mentions intravenous calcium gluconate. It is the IV form of calcium. If it is less in the body, obviously you will give, right? Second option says calcium supplementation. So oral calcium tablets, obviously you will give if somebody is having hypocalcemia. Third, maybe I don't know, I've not read the chapter phosphate supplementation. I'll go back to fourth option, periodic calcium level estimation. Now we all know that anything in excess in the body can be toxic, be it vitamins, be it minerals, be it any kind of thing. If it is given in excess quantity, it can be toxic. So definitely we need to mention and revise our treatment after doing the level estimation. So it's very important to see that what is the calcium level after 1 month of calcium supplementation, after 6 months of calcium supplementation, so that we have to stop or not. So common sense, simple common sense, even if you have not read hypocalcemia, you can easily answer. There is nothing to do with phosphate supplementation in this topic, right? So there's no need to be confused and be very afraid of MCQs. It's framed in such a way that the answer is right there. You just have to arrive at the answer, okay? So right answer over here is option number C. Is it clear to all of you? Please start putting thumbs up for those who are clear. If anybody has any doubt, please keep asking. Okay. Okay. Next question. Common causes of hypocalcemia are all except. Very important. Again, even if you have not read it, you can answer it. What in the body is related to calcium? Where all calcium gets metabolized? What all can be affected in the body resulting into hypocalcemia? Again, please remember it's asking you all except, which is not a common cause of hypocalcemia. Okay, Shankar has mentioned option number A. Any other response? Hypomagnesemia, vitamin D. Hyperparathyroidism. Okay, so Nitya, Satish. So, okay, right. That is the right answer. Option number E. So option number E is nothing to do with hypocalcemia. It will not decrease the level of calcium directly. So even if you have not read the entire theory, you don't know about the causes, you can use your common sense again. So we all know that calcium is very important for the bone health. I think everybody by this age should be knowing that why we eat calcium, because we need stronger bones in the body. And we all know that vitamin D is also to do with bone health. We eat vitamin D again to strengthen our bones. They do have n number of important functions, but supposedly you have not read this topic. So should you miss the opportunity of answering it right? No. You should always take a risk and use your common sense. So we know that vitamin D deficiency, if there, can result into decreased absorption of calcium also. So we can go for this answer. It can be a cause of hypocalcemia. Again, hypomagnesemia. So magnesium is the best friend of calcium. Okay, calcium and magnesium are very, very good friends. So wherever calcium is decreased, magnesium is also decreased. Whenever hypocalcemia is not responding to oral calcium treatment, we also give a trial of magnesium injection or magnesium sulfate injection. So magnesium, hypomagnesemia and hypocalcemia can exist in the body together because of certain syndromes and diseases. So hypomagnesemia is a very, very common cause of hypocalcemia, which is not due to common decrease in oral intake of calcium. Other important syndromes can result into this disease. Why increased phosphate load? Now, even if you have read your renal system properly, all of you must know that wherever there is increased calcium, there is decreased phosphate, and vice versa. Whenever there is increased phosphate, there is decreased calcium. So phosphate is not a good friend of calcium. So basically what happens, calcium and phosphate, they have a particular multiplication factor. So it will always go vice versa. Whenever the body has got increased phosphate, it is going to precipitate calcium along with it, and it will get deposited in the tissue. So what will happen then? It will get deposited inside the tissue. So that is why in the blood, the level of calcium is going to decrease. So please remember, phosphate and calcium go opposite, and calcium and magnesium go hand in hand. So that is very, very important to remember as a simple trick for the exams. Always remember, calcium and phosphate have opposite arrows, and calcium and magnesium have got same direction arrows. That means increased calcium, increased magnesium, decreased calcium, decreased magnesium. The opposite holds for phosphate and calcium. All right. Now, renal insufficiency, very common cause for calcium. Again, because the important hormones produced in the kidney, they help in absorption of calcium and also vitamin D in most of the parts of the body, especially your stomach, especially in the renal system itself, in the first part of the kidney, and also in the bones and skeletal muscles. So whenever there is renal shutdown, it will result into hypocalcemia and also decrease the magnesium metabolism and also affect vitamin D metabolism. So these are all important causes of hypocalcemia except hyperparathyroidism. Hyperparathyroidism will not cause hypocalcemia. Is that clear to all of you? Anybody who has doubts in this question? Please put a thumbs up, those who understood the concept. Okay. Any doubts, then please ask. All right. So can we move on to next question? Question number 4. Diagnosis of hypocalcemia includes. Now it includes which of the following? So what are the important things that is required for the diagnosis of hypocalcemia? Please put down your responses. Come on, please answer everybody. Very simple question. We have understood the causes of hypocalcemia, then we can easily mention the important investigations. Okay, option number A has come up, C, F, option number A. Would you like to go for LFT and RFT? Will renal function test help you to understand the cause for hypocalcemia? Yes, very good. B and D have come up, all right. Okay. All right. So that is absolutely right. All of you have answered it right. So we have understood the causes. If you understand the concept, you see it becomes very easy to answer the MCQs. Even if you knew the causes of hypocalcemia, you can easily answer the diagnosis and the investigations related to hypocalcemia. So phosphate levels and alkaline phosphatase level both can help us to diagnose because we have seen calcium and phosphate go in opposite direction. Alkaline phosphatase is usually increased in cases of hypocalcemia and also in vitamin D deficiency. LFT, RFT again will help us to diagnose of chronic conditions in the body like renal insufficiency, any kind of syndrome like Fanconi's disease. So wherever renal function is chronically affected or liver function is affected, they will also cause decrease in the calcium levels. Why X-ray chest and wrist? Because most of the time nutritional causes, which is very common in our country, vitamin D deficiency causes rickets. And along with the nutritional causes of rickets, calcium is also low in the body. So if we do an X-ray chest and wrist, what do we see? In wrist, we can see that the hands of the baby show an image like this. There are very rough edges on the X-ray that is basically fraying. We see the widened end of the wrist, which is playing. And we see there's a kind of cup kind of effect on this long bones. This is known as cupping. So if vitamin D is deficient in the body, most likely because of nutritional cause, calcium might also be deficient in the body. So hypocalcemia can also be diagnosed on doing an X-ray of chest and wrist. Why chest? When you see the rib, ends of the rib on the chest X-ray, they are widened out like this. Ballooned out ends of the ribs is a very common finding that we see in hypocalcemia. Why do we need to do ABG? Can anybody answer in the chat box? Why ABG can help us in the diagnosis of hypocalcemia? Ultrasound kidney, we can understand again renal problems can result into diagnosis of hypocalcemia because that is where the enzymes are formed and vitamin D and calcium gets absorbed. Laryngospasm, cyanosis, okay. All right. Metabolic acidosis, yes, that is the right answer. Very good. Who answered this? Acha, alkalosis, I'm sorry. Okay, I got impressed. Somebody mentioned the right answer. Absolutely. Decreased oxygen. Okay. So it is basically metabolic acidosis. So many diseases which have a renal shutdown. Yes, acidosis, that is right. So if we have metabolic acidosis, that is very commonly related to diseases like Fanconi's. So these diseases are very rare diseases which are X-linked traits in the body which have a complete renal shutdown, and they definitely affect the absorption of vitamin D and calcium. Now these patients will not present with common features of hypocalcemia. They will have frank rickets. They will not get treated by any kind of phosphate supplementation, calcium supplementation. They require injections of multiple doses of vitamin D in the active form and maybe calcium throughout their life. So there are many disorders which basically cause a renal shutdown. So they can be diagnosed with a very high values of metabolic acidosis on APG. So that is one important thing that we need to do in hypocalcemia, which is not getting diagnosed by other common etiologies. Okay. Thyroid hormone has nothing to do with calcium, and ultrasound kidney definitely will help us again to diagnose renal condition. So is that clear? Hypocalcemia, any doubts anybody has, please post. If it is clear, please put a thumbs up. All right. So let us move on to next topic. Very interesting topic. One topic that everybody is scared of, and one topic which everybody thinks somebody should teach me a way of learning this topic. But the trick is do not learn this topic ever. It is very, very important to just understand any type of heart disease. If you know the diagram, you can answer and understand the etiology, pathogenesis, diagnosis, treatment, X-ray finding, echo finding, everything. So it's totally concept based. Never try to mug up the causes, never try to mug up the clinical features. It will all get mixed and matched. Okay. LOFT, what is LOFT? Yes. So I said that wherever vitamin D is there involved, I gave you a simple trick. Wherever vitamin D is there, it will always be associated with calcium. So calcium and vitamin D go hand in hand. They are also friends, whereas calcium and phosphate go opposite. So wherever there's a chronic liver disease, CLDs, that definitely affects all the vitamin absorptions, which will ultimately go and affect the calcium levels also. All right. There is cirrhosis of livers, there is diseases like chronic liver disease, any kind of metabolic liver disease is very common in children. So all of these chronic liver disorders definitely affect the component of calcium and vitamin D both in the body. All right. Okay, let's move on to cyanotic congenital heart disease. Are all of you ready for answering the MCQ in this topic? Okay, first question, simple. TOF has got which of the following component? So what do we understand by tetralogy of Fallot? TOF. Very commonly asked in the exam. Must know topic. Every exam you'll see question on this topic. Okay. So B, C, D, and E have come up as the answer. B, C, D, and E. Please read the question carefully. The person who answers patiently knows the right answer. Okay. Now this is a classical example of shutting down your brain and not using your common sense in the exam. परे पढ़ाई topic से answer गलत करना. This is classically what we do in our exams. I have also done, I'm not praising myself, I have also done these mistakes, but you should learn from your mistakes. What happens usually whenever we are sitting in the exam kind of a situation, whenever a question comes, we are very happy that we have read this topic and we know that we feel that we'll answer it right. So we should spend more time on answering those questions which we have not read or we have doubts about or we have to use and exercise our brain. So as a reflex, what happens? We take these questions very lightly. TOF, so we have read, we know everything about TOF. And we just remember, yes, TOF has got 4 components, RVH, overriding of aorta, VSD, and right ventricular outflow tract obstruction. We just marked B, C, D, and E. But any student who has read the question carefully, I always say, please read the question carefully. TOF has which of the following component? Okay. First option is the most important thing. Why does the TOF happens? It happens because of anterior deviation of infundibular septum. Agar ye deviation nahi hoga, then why will the components arise? So that is the most important thing. Thank God, Nitya, you understood the question. So anterior deviation of infundibular septum is the most important pathogenesis in TOF. Now, if this thing is going to happen as a result of this anterior deviation, there is going to be overriding of aorta. There is going to be obstruction because of the infundibular septum being hypoplastic. There will be VSD to allow the shunt of the blood. And because of the shunting, there is going to be right ventricular hypertrophy. So it is all A, B, C, D, and E. ASD has nothing to do with TOF. It goes into pentology when there are 5 components in TOF. Is it clear to all of you? So please stop making these silly mistakes. Always be patient while reading the question. Many a times it happens, the question is very simple, the language is very simple. Still, we tend to make these stupid mistakes and lose on marks. Okay? Clear to all of you? So that is a simple concept. What is tetralogy of Fallot? Okay, next important question. Pathogenesis of TOF includes which of the following? So I just mentioned what happens in TOF. If you have listened carefully also, you might be able to answer this question. Please take time to read and understand. Anybody would like to attempt this question? Okay, Preeti has answered A, B, C, D. Siddharth has answered option B. Okay. Any more responses? All right. So Preeti, very good. Again, your answer is right. So it includes all the four components A, B, C, D. Now, even if you understand the pathogenesis, you have just learned that there is right ventricular outflow tract obstruction, which we also discussed in the previous question. So how is the obstruction happening? Obviously, there is some problem with the pulmonary valve. So the first option mentions normally to severely hypoplastic pulmonary valve. Yes, that can be there. Valve stenosis again means the same thing. Hypertrophic cystic supraventricularis again means the same thing. If it is hypertrophy, there will be less space for the blood to pass out from the right ventricle towards the outflow tract. And fibrous, severely hypoplastic or absent pulmonary valve. The valve is completely stenosed and is not present or absent. Again, it means the same thing, that is RVOT. So when you can answer that in components of TOF, we have RVOT as a component, then why can you not answer this question? So again, it's very, very simple to understand. Please read the question patiently. Try to figure out what is the meaning of the options. It all means the same thing, RVOT. So whenever there is RVOT, the blood will not be able to flow from right ventricle towards the pulmonary artery. So ultimately, it is going to result into this defect of TOF. The blood will get shunted towards the left ventricle. There is no septal defect in the ventricle. Is that possible? Obviously, this is wrong because we just read that VST is a component of TOF, right? So VST is a septal defect in ventricle. So option number E is absolutely wrong. And all A, B, C, and D are correct. Is it clear to all of you? Is it clear? Please put thumbs up. Any doubts, anybody? Okay. All right. Okay, next, let's move on to third question. Common clinical features of TOF are, again, if you know the concept, no need to memorize the clinical features individually. You can read the question, use your concept and choose your options very, very patiently. So please read each option and try to put it in the chat box. Okay. Cyanosis, clubbing, dyspnea, systolic murmur. All right. A, C, and D. Okay. Any other response? Would you like to add on to anything? What about option B, E, and G? A, B, C, D, E, and F. Okay, B is also there. All right. So Preeti, again, it is right answer, but there's a confusion in this question. See, if there is systolic thrill and systolic murmur, because both of them means about the abnormal sound. So which one would you choose? Can anybody go for the option? Would you prefer to answer option E, or would you prefer to answer option F as a component of TOF? Yes, very good. So systolic thrill is more prominent in a patient of TOF as compared to systolic murmur. Okay, so apart from this cyanosis, we all know why it happens because of mixing of the blood. Gray sclera, why does it happen? Because of chronic hypoxia. So it is not present in the immediate neonatal or infant period, but those children who have TOF, which is not surgically corrected in old age, like maybe 5, 7, 8 years of age, they will develop gray sclera because of chronic hypoxia. Clubbing is a classical clinical feature. Even if you see the hands of these children who have TOF, they have got hypertrophied nails. So that is again seen because of chronic hypoxia. Dyspnea on exertion, obviously, because there is decreased SpO2 in the body due to mixing of the blood. So because of hypoxia, there is going to be dyspnea on exertion. Croupy cough is nothing to do with TOF because common sense again, we learned RVOT is a component of TOF. So if the right ventricular outflow tract is obstructed, the blood will not go to pulmonary artery. From pulmonary artery, too much of blood will never go to lungs. If the lungs is not overloaded, why will it cause an effect of cough or any kind of LRTI? So please remember LRTI or pneumonia is never seen in TOF patients. Okay? So that is a very common confusion. LRTI and pneumonias are classical features of acyanotic congenital heart disease, not in cyanotic heart disease, because in cyanotic heart disease, there is problem in RVOT. So the blood is not going to get overloaded in the lungs. So children will never present with pneumonias and recurrent chest infection. So that is absolutely wrong for TOF. Okay. Now coming to this point, whether E or F. See, thrill basically happens because the right ventricular outflow tract is obstructed, because of which there is right ventricular hypertrophy. Now, when the ventricle is right in front of your body, now one very important joke, as doctors we all must have heard, when you give your heart to somebody, what do you give? Which part of your heart do you give to people? I mean, your boyfriend or girlfriend? If you have heard that thing. Anybody who can answer this question? Whether it is right atria, right ventricle, left atria, or left ventricle. Which part of your heart do you give to your love? Anybody who can answer this? Nobody has given their heart till now. Right, what right? Atrium or ventricle? Very sincere kids, nobody has fallen in love till now. So it is the right ventricle. So when we say that I have given my heart to you, basically in medical terms, we mean we have given a right ventricle to you. Why? Because right ventricle is present right behind your mediastinum, right in front of the chest. So that is why this joke, it will help you remember in TOF. So right ventricle hypertrophy is going to happen. What will happen? Your chest is going to bulge out because it is present right behind the sternum or the chest wall. So if right ventricle hypertrophy is there in TOF, you will feel a systolic thrill. If you palpate the chest of that child who has TOF because of right ventricular hypertrophy, the thrill is very, very commonly seen or commonly felt. So thrill is the more predominant component over murmur. Why not murmur? See, murmur basically happens because when in the heart, this right ventricular outflow tract is obstructed, the pulmonary valve is stenotic, right? If it is stenotic, it depends on the degree of stenosis. Now, supposedly the stenosis is very, very pronounced. It is completely stenotic valve or the absent valve. Then the blood will not be able to flow through it. If the blood is not flowing through it, it will not produce any murmur. So there are cases of TOF where the murmur is very, very minimal. So you can miss on auscultation. That is why if you have to choose between thrill or murmur, you will always go for thrill over murmur. Is it clear to all of you? Please put a thumbs up those who understood this concept. Okay. All right. Any doubts, anybody? Please keep asking. TOF is a very, very important topic, must know topic. Every year question is going to come from this. Okay. All right. So common clinical features are all of these except LRTI, pneumonia, cough. Okay. Okay, next question number 4. Hypoxic spell shows which of the following? So what are the common things that we see when a child goes into hypoxic spell or TET spell or cyanotic spell? Please put down your answers. I think I just mentioned the answer in the previous discussion. It's so useful for you because whatever is coming as the next question, I already discussed in the previous question in terms of explanation. Okay, B has come as the answer, C has come as the answer, E has come as the answer. Okay, what about A? Is this hyperapnea is there or not? Preeti, please answer carefully. Why option number D? Didn't I just mention right now, whenever there is RVOT. Okay, let me start with the concept again. Paroxysm of hyperapnea is always there. This is our heart. This is right atrium, left atria. Right ventricle, left ventricle. Once you understand this diagram, you don't need to memorize or mug up anything for TOEFL. Okay? So this is the chamber of the heart. We have pulmonary artery over here. We have the aorta over here. Okay? There is a very important thing in this. We have got a shunt, that is VSD is over here. Now this is the pulmonary valve. Now pulmonary valve can have different degrees of stenosis. It can be completely stenotic. It can be partially stenotic. It can be completely atresia. That means it is not formed at all. Okay. So depending on the degree of stenosis, the blood flow depends on the degree of stenosis that is there. Now what happens in a hypoxic spell basically? So in a hypoxic spell, a child first of all who has TOEFL definitely starts to cry or becomes irritable because of any reason, maybe because of hunger, because of anger, any kind of reason. The child starts to cry. Once the child starts to cry, what will happen? There are catecholamines that are released in the blood. Okay. Now these catecholamines go and act on the valve, that is the pulmonary valve. Okay. Now it has got alpha and beta receptors over here. Now because of its action on the valve, what is going to happen? Whatever is the degree of stenosis will increase at the time of hypoxic spell. So when there is hypoxic spell, one important phenomena that all of you should remember is increase in stenosis. Now, whenever there is increase in stenosis, what will happen? This pathway that is there for exchange of blood becomes all the more difficult, right? So it will become completely obstructed. Whatever was the degree of stenosis initially in normal stage of TOEFL will increase when the child goes into cyanotic spell. Now, whatever blood that was able to pass through that pathway will further decrease, right? Because the pathway has become more shrunken. Now, if the blood is not going out from the right ventricular outflow tract, where will the blood go? Anybody can answer? All the blood is accumulated in right ventricle. It's getting overloaded. What will happen to the blood? Please put in the chat box. It is not able to go over here. Where will the blood go? Right atrium. Why right atrium? The pressure will go up or pressure will go lateral. What is easy for you? To move from one side to other side or to climb up the mountain and go on Mount Everest? Blood will never go up. The pressure in the body is towards gravity. So the blood will go to left ventricle. Okay, that's right, Siddharth. And Darshini, the blood will go to left ventricle. Okay. And Nitya also answered it, right? So left ventricle, what does left ventricle have? Very important thing, it has got purified blood that goes from the aorta to the whole body. So if the blood gets mixed with the dirty blood of right ventricle, what will happen? This dirty blood will go and get pumped to the entire body of the child. That is why in cyanotic spell, what will happen? First, the child will start to hyperapnea. Why? Because saturation of oxygen is falling in the body. The child will try to increase the respiratory rate to gather more oxygen. Irritability, prolonged cry was the initial thing which started the entire vicious cycle. Cyanosis will obviously increase. Why? Because the blood has become dirty. More mixing of blood is happening because of stenosis, and that is why saturation will drop. And the most important thing that we have to do is to put the child in knee chest position, give oxygen support, soda bicarb for the treatment. Now, what is the concept of putting in knee chest position? Can anybody tell me in one single word? Why does a knee chest position help in treating cyanotic spell? Fast, anybody please? Put in the chat box. What was basically happening over here? The blood was getting mixed in the left ventricle. So what do we want immediately to happen? The blood not to get mixed in left ventricle, right? So what do we do? Yes, very good. Systemic resistance. We want to increase the SVR. So if we put the child in knee chest position, what will happen? The femoral vessels will get compressed. So once it gets compressed, the systemic vascular resistance will increase. If it will increase, the pressure will increase in left ventricle, which will not allow the blood from right ventricle to get shunted to left ventricle. So the mixing of blood will temporarily stop. That is why the blood will be there in the right ventricle. And now because the pressure has increased over the right ventricle, the stenotic pathway will further try to come back to its normal state and the blood will pump out from right ventricle to the outflow tract and the symptoms of cyanotic spell will improve. Is it clear to all of you? Have you understood the entire concept of cyanotic spell? Please put a thumbs up those who understood. All right. So treatment, presentation, and the first most important step is to put a knee chest position. Don't start shouting for your seniors, ma'am, please come, sir, please come. See, the baby has turned blue. The first important thing is to just hold the baby and put in knee chest position. Okay. All right. Next important question from diagnosis of TOF. So diagnosis of TOF includes all except. Now, if you have understood the entire TOF and pathogenesis, very simple to answer. What is not important for diagnosing a TOF? Fast, put down your answer. Very simple question. Very good. E. Cardiac markers are always important for infective causes. Very simple to know. Infective causes like COVID, myocarditis, they help to diagnose on, they are getting diagnosed on cardiac markers. Clinical diagnosis very important. If you see gray sclera, cyanosis, clubbing, all of these important clinical feature can help you to diagnose TOF. Chest X-ray, we find a boot-shaped heart on chest X-ray. 2D echo, you can see all the important components. You can see VSD, you can see right ventricular outflow tract obstruction, you can see overriding of aorta. Everything is clear on 2D echo. ECG, why ECG will help? Can anybody put in chat box? What will you see on ECG in a case of TOF? Come on, very simple, we just discussed. Which component can be picked up on ECG? Very good. Right ventricle hypertrophy. So Nitya has answered it right. So that is about TOF. It is very important topic. Please revise it in detail. Please listen to my class in detail. And it's very well explained. I've tried to put it in simple words so that you understand the concept and any question that comes from this topic is very, very easy to answer. All right. So let's move on to next question. Management of TOF includes all except. What is not included in the management of TOF? Again, if you know the pathogenesis, you can easily answer this. What is propranolol? One important clue, it's a beta blocker. So use your common sense. We just discussed about alpha and beta receptors. Okay, Siddharth has answered option number B. Any other response? Okay, so see, iron deficiency state is very, very important. Yes, right, Preeti, MVR is nothing to do with this. MVR is surgical procedure that is done in valve defect. So oral propranolol therapy is the treatment of choice because beta blockers will help to decrease the stenosis level and the degree of RVOT. So that is definitely prescribed to all patients of TOF. BT shunt and modified BT shunt is the ultimate treatment of choice in surgical terms because they are the corrective surgeries that is done in patients of TOF. MVR has nothing to do over here. Now, iron deficiency states are very, very important to treat because the more decrease in iron is there in the body, the more less level of oxygenation is going to be there. Already a TOF patient has got decreased oxygen in the blood, so we don't want them to suffer any kind of complications. Like if there is decreased oxygen level in the body, it can result into thrombosis, right? So we don't want them to suffer any kind of neurovascular accidents. That is why whenever the hemoglobin levels is low, we tend to supplement it either with blood transfusion or iron supplementation. So treating iron deficiency, oral propranolol therapy, classic BT shunt and modified BT shunt are all important treatment protocols for TOF. Is it clear? Is it clear to all of you? Please put a thumbs up. All right. Okay. Next, we are going to move on to nephrotic syndrome. Very important topic again. So we have taken most of the important topics so that everybody gets very, very energetic to learn pediatrics now because it's very important to learn these topics. It's all concept based. If you know the topics, you know the important values, you can answer it. Okay. All right. So what is nephrotic syndrome? Very important, simple question. What is the definition of nephrotic syndrome? Multiple answers. Please put down your response. Come on, everybody, please put down your response. What is nephrotic syndrome? Okay, Darshini has answered option A, option D, option E, and option F. Any other response? A, B, C, D, E, F. A, B, C, D, E, and F. All of them. How can all of them be right? The examiner has made the question in normal senses. Something has to be wrong. Okay, so please remember the values. It is very important. Don't get confused with the values. It's very commonly asked question. So nephrotic syndrome is a disease of proteinuria, that is protein loss in the body. But how much protein? More than 3.5 gram in one day, 24 hours, or more than 40 milligrams per meter square per hour, or 1 gram per meter square per day. So please remember these values by heart. It is the classical definition of proteinuria in nephrotic. Okay, spot UP-UC ratio. UP-UC ratio more than 2. Very, very important. Spot UP-UC ratio more than 2. Dipstick, how much is the dipstick value? It is not 2, it is 3 plus. So if it is more than equal to 3 plus, it is a definition criteria for nephrotic. How much is the albumin level? How much is the protein loss? Can anybody tell me the right value of albumin cutoff in the body in nephrotic syndrome? Please type in your response. 3, no, little more low. It is 2.5. So if it is less than 2.5, it is hypoalbuminemia. Once the albumin levels in the body falls, plasma oncotic pressure will decrease and therefore the fluid will get accumulated in the body. So anasarca is definitely important in nephrotic syndrome. Hyperlipidemia is also right. So cholesterol more than 200 milligrams per deciliter. All right. So what is wrong over here is hypoalbuminemia and dipstick of 3. These two options are wrong. Okay. Rest all of them are right. Yes, Nitya, that is 2.5. Very good. Okay, so please remember the definition of nephrotic. It's very, very important. Okay, next we have what are the clinical features of nephrotic syndrome. Now, if you have understood what is proteinuria, what happens in nephrotic, you can easily answer the clinical features. Even if you don't memorize it, you can use your common sense. It is a renal disease in which the protein is getting lost in the body. Now, protein includes many things. It does not only include albumin, it includes all the important immunoglobulins. It includes transferrin. So what could be the clinical features? A, B, C, D, E. Okay, any other response? A, D. Okay, A is common. B, C, C is also not common. Respiratory distress is there. Genital swelling and fever. Okay. All right. So generalized anasarca, I hope all of you understand because albumin level has decreased. So what will happen? Oncotic pressure will fall. Fluid accumulation will happen in the body. It's a classical presentation of anasarca. Obviously, if the body is having anasarca, genital swelling will be present. Respiratory distress will be present because of fluid overload. Hypertension is very commonly seen in nephrotic syndrome because of renal problems. So that is a very common clinical feature which is seen in nephrotic. Although it is not very commonly seen in all types of nephrotic, but certain subtypes of nephrotic can have hypertension. So you cannot exclude it. Okay. Fever is present again by immunoglobulins. If it is lost from the body, what will happen? The child will have increased probability to catch infection. So fever is again common. Urine output will not be decreased. Urine increased. It is going to be decreased urine output. Why? Because the renal functions are not normal. The child will have a decreased urine output. So that is very important to understand. So the important clinical features of nephrotic will be generalized swelling of the body, hypertension, decreased urine output, recurrent infection. Okay. Is it clear to all of you? Please put thumbs up those who are understanding everything. All right. Okay. Great. Okay. Next question. Investigations for nephrotic syndrome include. So what all would you like to investigate in a child of nephrotic syndrome? Please read the question and options patiently and try to answer. Please put down your responses. Come on, fast, everybody, put down your responses. Okay, A, B, C, D, all right, and E. Yes, so that is absolutely right. There is no rule of doing a CT abdomen or CT pelvis. Why we want to do a CBC? To rule out infection, to see the TLC count, and also the fall in hemoglobin. RFT obviously because renal function is affected. Electrolytes obviously because renal function is affected, right? Chest X-ray. Why do we want to see chest X-ray? Again, to rule out infections and pneumonias, and also to see evidence of fluid overload in the chest. Okay. Routine urine examination is very important. Why? Because all the tests will be done from urine. UP-UC ratio, urine culture sensitivity, urine routine RM, and also we can do the 24-hour urinary protein loss, which will help us to diagnose nephrotic syndrome. So urine test is very, very important. Ultrasound abdomen, again to see what is the renal dysfunction that is happening, whether we are confusing it with any other important causes of a renal shutdown. It could be a nephritic, it could be pyelonephritis, any kind of congenital anomalies like hydronephrosis. So ultrasound abdomen is very important. Apart from that, it also helps us to diagnose anasarca. That is how much free fluid is accumulated inside the body. Now, those who have not been able to answer HIV and TB workup, it's very important in nephrotic syndrome. Why? What is the treatment of nephrotic syndrome? Please answer in the chat box. What is the treatment of nephrotic syndrome? Steroids, right? So before starting steroid, if the child has TB, now TB is very common in India, right? If the child has latent TB, it can get flared up because it will cause immunosuppression. So we always want to rule out TB before starting steroids in any condition, be it nephrotic or any other autoimmune disorder. So TB workup is very important. HIV, again, it can get flared up, or the symptoms can get aggravated by starting steroid therapy because it will further decrease the immunity levels of the body, right? So A, B, C, D, E are the important investigations for nephrotic. All right. Now, what are the complications of nephrotic syndrome? If you have understood all the important things that we have discussed till now, you can tell about the complications of nephrotic. Okay, loss of protein, infection, coagulable state, renal failure. That is right. Congestive heart failure is nothing to do with nephrotic because congestive heart failure will not happen in nephrotic syndrome. There could be respiratory distress because of fluid overload. Loss of protein is a classical thing that happens in nephrotic. It can result into anasarca. Infections because immunoglobulins are getting lost from the urine. Hypercoagulable state because important proteins like protein C, protein S, these which are important to maintain the coagulation profile in the body, they are also getting disturbed. So hypercoagulable state will be there. Renal failure, again, if it is not getting treated in time, it can result into complete renal shutdown. Convulsions can also happen. Why convulsions will happen? Because of electrolyte disturbances in the body. Okay. Another cause could be hypertension, which can result into hypertensive encephalopathy, resulting into swelling in the brain causing convulsions or brain edema. So convulsion again is an important complication. Is it clear? Let's move on to next question. Okay, what are the dietary modifications in nephrotic syndrome except? Please read the question carefully. All of these are dietary modifications except. Okay, this might be a little difficult to answer. Okay, now dietary modifications, see if you have understood the pathogenesis, what is happening, protein is getting lost. So we have to supplement with adequate protein in the body. Yes, option number D has nothing to do with it. That is right, Preeti. So that is the right answer. So adequate protein has to be given because there is protein loss. So at least 1.5 to 2 gram per kg of the body weight is to be consumed. Persistent proteinuria is there, then a little higher dose, that is 2 to 2.5 grams per kg of protein has to be consumed. The fat component should not be more than 30% of the total calorie intake. Why? Because there is increased cholesterol already in the body. Saturated fats are not allowed because there is increased cholesterol already. Salt needs to be restricted so that water retention is decreased in the body. Okay. So at least 1 to 2 grams per day of salt can be allowed, not more than that. So these are the dietary modifications which are advised in a case of nephrotic syndrome. Is it clear to all of you? Any doubts about these topics, please keep asking in the chat box. So we can move to the next topic. Please put your thumbs up, those who are understanding everything and still listening to the class. All right, I think everybody's understanding everything. That's very nice. Okay, simple topic, Strider. We are moving towards the end of the session. So simple topics, little more MCQs to be done. Strider is, what is Strider? Very simple question, what is Strider? Option number A, yes, that is right. Any other option that could be correct? It is basically a harsh kind of a high-pitched musical sound that is produced when the airway is obstructed because of any cause. It could be infection, inflammation. It may be inspiratory, expiratory, or biphasic depending on the timing of the respiratory cycle. That is right. Both option A and B are correct. Inspiratory stridor, always remember it's vice versa. Inspiratory stridor is because of extrathoracic cause and expiratory stridor is because of intrathoracic cause. So these two go wrong. A and B are right. Okay. Yes, very good. I think all of you know this answer. What are the causes of stridor? When does the stridor happen? Okay, this is the airway. This is the vocal cord. Sorry, my drawing is very bad. So this is some kind of narrowing that can happen at any level. So what could be the causes of stridor? So the part above the glottis is supraglottic. This is the glottic part, the vocal cord part. And just below it, which is the most narrow part, is the subglottic part. So anywhere if the obstruction is present, it can result into, yes, it could be foreign body, it could be anything, any kind of inflammation, laryngotracheobronchitis, tracheitis, any kind of abscess, all of them can result into obstruction of the airway. So partial supraglottic obstruction, partial obstruction of the glottic part, or partial obstruction of the subglottic part, all three can result into onset of stridor. Okay. Ludwig's angina cannot result into stridor. It can result into difficulty in breathing, but it will not be so obstructed that it can produce onset of these kind of sound. Okay. All right. Now, what could be the causes of stridor? Acute stridor can be seen in which of the following cases? So please understand, it's asking you acute stridor means something which has just happened recently. Even if you don't know the answer, you can easily answer. Foreign body, obviously, if the child ingests a foreign body which goes in the airway, obviously stridor will happen. Laryngotracheobronchitis, croup is an infection. So all the infective causes will be acute. So we can go for croup, we can go for tracheitis, we can go for all abscess, we can go for epiglottitis also. Okay. All right. But tonsillitis cannot cause stridor. Why? Because tonsillitis is inflammation of the tonsils. The trachea is very, very wide over here. It cannot cause so much of compression that the airway will get obstructed. Okay. But epiglottitis will affect the vocal cord. Peritonsillar abscess will affect the vocal cord. Retropharyngeal abscess will also affect the glottic area. So it is very simple to know all the causes which affect the supraglottic part, glottic part, or the subglottic part can cause stridor because these are the areas where the airway is very, very narrow. And aspiration of foreign body because it's very huge as compared to the size of the airway. And laryngotracheobronchitis, croup will again cause inflammation in these parts. It can result into onset of stridor. Okay. So just remember simple thing. Any kind of foreign body or any kind of inflammation and infection of acute onset can cause stridor. Okay, what are the examples of chronic stridor? Now, something which is present already in the airway. What things can cause a chronic stridor? The child since 1 year of age is having noisy breathing. If a mother comes and say, for last 1 year, the baby is having noisy breathing. So what could be the causes of chronic stridor? We just discussed in the previous slide, very simple. Things which are already present as a deformity, like laryngomalacia, it can cause chronic stridor. It's not an acute onset. Subglottic stenosis can result into chronic stridor. Why? Because if the stenosis is already present congenitally, it's not treated, then it can continue for more than 1 year, 2 years. Yes. Vocal cord dysfunction, if there's some kind of nerve anomaly, nerve supply anomaly in the vocal cord, it is not getting abducted and adducted properly, it can again cause chronic stridor. Any kind of space occupying lesion like a web, any cyst, any papilloma can again be present as congenital problem in the baby. It can cause chronic stridor. Tracheomalacia, if the entire airway is only weak, tracheomalacia means that the trachea is weak. So that will again cause stridor. Foreign body is always an acute onset. It is not a chronic onset of stridor. Is it clear? Yes, A, B, C, D, E, F, all are right except foreign body. Okay, very simple question. What is the management of stridor? What we are going to do if there's a patient who has stridor? Simple, the airway is obstructed. What can we do? We'll maintain the airway, most important step. Very good, Siddharth. A, B, C, D. That is right. Nitya right. Darshini right. So airway we have to maintain. We have to give a complete. Very good, Preeti. Again, right answer. So airway has to be maintained. We have to position the neck and the body so that the obstruction part gets relieved. If there is stenosis, if you position the neck properly, there might be relief in the amount of obstruction. Oxygen, again, because the airway is obstructed, it will fall the level of oxygen in the body. So we need to give extra oxygen. And whatever is the cause, maybe a foreign body, any kind of croup. So whatever is the specific management like nebulization, steroid therapy, removal through bronchoscopy, that we have to do. Tympanoplasty has nothing to do with stridor. So very simple topic. These kind of simple questions can also come in the exam, which you should not miss and should not get confused how to answer. Okay. All right. The last section for today's class, normal neonate. Are all of you in your senses to continue? It will take 5 more minutes. Please put your thumbs up. All right, everybody's awake till now. Very good. Okay, very simple thing. A normal newborn, everybody must have seen. They look so cute when they are born. Everybody must have played in the labor room with a normal newborn. So let's answer a simple question. What do you do as an immediate newborn care? When a newborn is brought to you after delivery, what all things would you do? Let us just discuss it normally, no more asking to you. Very simple. Will you maintain the body temperature? Obviously, the newborns are very prone to hypothermia, so we have to give them a nice warm environment. BCG vaccination is not something which is a newborn care. It is definitely immunization, but it is nothing to do with a newborn care. Okay. Open the airway, very, very important. You have to suction out the important secretions that is present. Initiation of breathing, very important. You have to see whether the child is able to have normal breathing pattern or not. Maintenance of circulation, very important. If the child is turning to be blue, if the child is having low pulses or the child is in shock, you have to give IV fluid bolus. So as we all know, A, B, C, airway, breathing, circulation, that is all that we do in a normal newborn also. Okay. Next question. Apgar score includes all except. What is not included in an Apgar score? Number of feeds tolerated. Okay. Very simple to know. By the name of Apgar only you can remember the mnemonic. A stands for activity. P stands for pulse, or you can establish the circulation. G stands for grinase. A stands for appearance, whether the baby is pink or blue or is having some amount of acrocyanosis, and R is for respiration. So no more confusion in Apgar score from now. Apgar simply stands for Apgar. Okay? So you can remember the components of Apgar by this mnemonic itself. Okay, body temperature of the neonate can be maintained by, very simple. What do we do to along with other clothes also? Delay the baby bath, that can be done. KMC is the most important thing for a mother to do to maintain the body temperature. And the temperature of the neonatal ICU and labor room should always be 28 to 30 degrees Celsius at least. Regularly keeping the baby in warmer is not required. The normal baby can handle the temperature itself, but it is important to keep the baby properly clothed. So these are the important things that can be done for body temperature. Okay, well, another very, very simple question. What is the care of umbilical cord? So the cord that is there, which we cut at the time of delivery. What all should we do for the umbilical cord care? Let us read simultaneously and understand. Sterile instruments must be used to cut and clamp the cord. Yes, we always use sterile blade and sterile scissors. Inspect the cord for 2 to 3 hours for bleeding. Very, very important. The cord can bleed if the clamp is loose. We should always inspect for any active bleeding. Keep the cord dry and free of infections, very important. So these three are important cord care. Delayed fall of the umbilical cord is considered normal. No, that is not right. It is abnormal. And at the end of the session, anybody who answers what is the diagnosis, which disease is diagnostic, if there is delayed cord fall, that means that child, that person, that student has read the entire pediatrics till now. Delayed cord fall is indicative of which disease? Anybody who can write down the answer? And the last question is, high-risk newborn are all except. Now, please remember, high-risk newborn are those which do not fall in the criteria of normal neonate. Omphalitis, no. So if the birth weight is less than 2.5 kg or more than 4 kg is abnormal, so they become high risk. Okay. If the birth time is less than 37 completed weeks or more than 42 completed weeks, again, that is abnormal, so it becomes high risk. If the baby size is small or large compared to normal, again, it is high risk. If the baby is having respiratory distress, again, it is high risk. If the baby is having cyanosis, pallor, or petechiae, again, it is high risk. Babies who are born by instrumental delivery, no, it is nothing to do with abnormality of the baby. If the baby is breech, if the baby has been delivered by vacuum or forceps, it is absolutely normal. It might be required at certain times, so it is absolutely normal. So the birth weight, the gestation age, the weight of the baby, any abnormal clinical features. If these are present, then only we count that particular baby as a high-risk neonate. All right, so with that, we come towards the end of the session. So I hope all of you understood the important topics, and I hope you must have read through these topics. Nobody has been able to answer that question. It is a bonus question. Anybody? Okay, so that the answer for that question is leukocyte adhesion defects, or LAD. That is a type of immunodeficiency disorder, but that you will only know when you mug up your entire Nelson and you come to a level of MD Pediatrics. That was just a normal question to ask for, just to increase your excitement level to read pediatrics. All right, so all of those who understood the session, please put a thumbs up. Was it good? Was it bad? Please put down your responses in the chat box. Those who are still listening, we are just going to end the session now. Okay, thank you. It was good. It was nice, very useful session. Okay, thank you, Darshini. Thank you, Siddharth. Thank you, Preeti. Thank you, Nitya. So all of you have been very interactive. Thank you, Sudha. Okay, even I enjoyed taking the session. And thank you for answering so well. I didn't expect you would answer so many questions rightly. Yes, we are coming up with more such sessions. So 2 or 3 sessions will be scheduled. Again, we'll take up 6 important topics from pediatrics and discuss the MCQs. And my point is not only to tell you the answer. My point is basically to help you understand how to arrive at the answer, so that out of 10, 12 questions from pediatrics, you don't miss a single question in the exam. At least you give it a try. Maybe you can do 1 or 2 wrong, but have your patience in the mind. Try to use exclusion criteria, word associations, all mnemonics, all tricks, and try to answer them rightly. It's not very difficult to learn pediatrics. It's very, very easy, provided you give up the thought of mugging up the notes. Please try to understand the topic as much as you can. And because questions keep changing every year, it's not like you'll get simple, questions picked up directly from the text. You can get applied questions. So if you know the topic, you'll be able to answer. Thank you all of you for being so patient and answering so well. We'll meet up again very soon with these questions on another important 6 topics in pediatrics. All right, thank you and good night.